Typically, Laura Sullivan would give you the state updates, but in her place, we have Leo Sarkisian. And today we're going to be talking about visitation and testing and transition. All very, very concerning and, a lot of things to think out. So why don't you take it away, Leo?
Thank you.
And
thank you, Carrie. And Carrie and I haven't been in the same room for a while. So I don't think I've seen your face in a while, Carrie. So, for all I know, you've colored your hair, you've got black hair now, instead of blonde.
Yeah, no, I just got a haircut this morning, and I've gained 5 pounds. So there you go.
I think a few of us are in that pound area. Yeah, I would think. Hi, everybody. Wow, what a time. It's week number 10, is it? It has been a remarkable time. And actually, it's probably, it's week number 10 right now, tomorrow. Since the order. And the only good news is, well, that's not true. There's a lot of good news. In fact, the issue, the advocate, that this issue will come out by email and posting, not by print, but we haven't decided if we'll just stick with that approach because we actually have a full color issue. We have a lot of gratitude during this period too. And I think it's sometimes hard to have gratitude if you're one of those individuals who's lost someone, or you're one of those individuals that's tied up 24/7, or you're a caregiver. So in our interview yesterday, Brittany McDermott sounded very upbeat, and they've been in the trenches for the entire 10 weeks. The virus started out in Berkshire County first. Well, it wasn't necessarily first there, but in terms of quarantine homes, I would say that's when I first heard about it. So it's really tough to sometimes see the glass half full. And obviously, we're all at different places and that we're unique individuals with or without disabilities. So welcome today. I want to focus on this because there had been some, more especially in others, Carrie got some feedback from family focus groups about testing and visitation. And then I thought, well, really the transition period's really good to talk about, like what's going on here. And they also felt like I should remind people about the breadth of the advocacy that we've been doing because, sometimes people have a very definitive opinion about the world and they sometimes don't know the breadth of what we're doing. So let me just start with, for those of you yesterday, I'll go fast through the slide just because it's the same stats. I didn't redo the stats with yesterday's number. But again, we're looking at from 890 people who had died the last time I did this, which was probably about 9 days before because it was a Monday versus, and it might have even been 10 days because it would have been a Friday statistic. 890 people had passed away when I did the check in that week. And the number of people who died went to 535, though in America, as you know, we're at 100,000. So it was a pretty sad benchmark that we passed as a country. And the total number of cases, rose by 67, almost 5,800, but it had been rising by 7,200 to 7,500 the week before or 10 days before. And then numbers of people tested, it's been steady in the 70,000 range. It was actually closer to 67, 68,000 the last time I talked about that statistic. So for those of you that weren't on yesterday, I wanted to just share those statistics. Today, there'll be statistics on our world. There'll actually be statistics posted. We're going to look at the command center. It might have already been posted. It didn't occur to me that they might have posted it first thing. But I understand through Representative Josh Cutler that there will be a dashboard for congregate care homes and specifically one on Department of Developmental Services. So that's great. And I just want to remind people sort of the breadth of the activity. 1,100 of you joined with us to send letters to administration to talk about the crisis standards of care in the very beginning. If you recall, we were very worried what would happen with ventilators and what would happen with people in the hospitals and the kind of care they would get. And the good news is it never got as bad as we were fearful of. And so ventilators, being deprived of ventilators, never happened. But your advocacy was huge. And that was something that was a very key advocacy point for us. In addition, we advocated for more awareness of the medical field, those people that were going to be triage members, and basically set up a healthcare triage page, which included 3 videos and a bunch of pictures and stories, so people would see people as individuals. And I also want to say we were part of 2 collaborations in that process with law centers and other groups, and really appreciated CPR taking the lead on the letters on the crisis standards of care. And since then, DLC has taken the lead on the hospital accommodations, which was part of our advocacy, making sure people were able to go with other folks who needed it into the hospital. And we have, a couple of weeks ago, WBUR played the story of Mary Henderson, who unfortunately in that hospital experience was not allowed to have family or caregiver with her when she passed away. And she had had dementia for some time, and in the previous hospital stay, she had that. So hopefully her story can help us prevent that happening to someone else later, especially if we have a recurrence. And then we worked on more, advocating for more specific guidance, more testing, more PPE. We advocated for more funding for the service system. It's not on this list because this is a later list. And that PPE and visitation. So people have been talking about that out there. So those are the things we've been involved in. I gave you the short version because, we like to keep these webinars to a half hour. So maybe at some point we'll have more in-depth talk. And then here's some of the outputs. We actually contacted, in addition to the things we shared about, I didn't mention the 4 weekly webinars and the 500 community survey responses we received early on, and 32 hospitals we contacted during that fair that we had about triage. So thank you to Charlie and others who had worked on that, Maura, Vicki Allen. So it was like a full court press to try to get to the hospitals. And a lot of volunteers, by the way, took our template and also shared it with the hospitals. So now I'd like to also introduce someone who's going to be sort of a co-facilitator with me and responded. Someone who's really overseeing things on the ground, literally, a good colleague of mine and friend. And she's especially good to have because she's been looking at the situation, has some very definite opinions. And that doesn't mean, by the way, we all don't have to agree on these things, but we do want to have facts and information that you get that helps you understand why we, might have a position we might have, or, and even Jean and I aren't always 100%, but Jean is a great resource. So Jean Phelps is our co-facilitator, and is a guest today, which I really appreciate, Jean, you making the time. And you can say hi before I introduce you to everybody with a few kudos. There she is in chartreuse, probably not pink. What do you think, Jean?
Pink is fine.
Pink is fine, okay. And I had to really hunt for that. And I was tired last night, and I'd saved Anne Marie's picture by mistake. I hadn't replaced it. So it would have been weird if I hadn't checked this a few minutes ago. But she's the CEO of LIfeLinks, now LIfeLinks CLASS, and she's been the CEO since 2008, which I can't believe because I remember when she took that position. So it does seem like yesterday in some ways, but not really. And she has 30 years of experience in the field. She's an MSW as I am. She, so that gives her some cred with me, She's the former chair of the trade organization as well. She played that role for a few years, and she had her hands full. And then she was past chair of the Mass Chapter of the American Association of Individuals with Intellectual and Developmental Disabilities. It's like a famous, precedes the ARC historically as the sort of professional group out there across the country. And I think in the last 10, 15 years, it's been in a resurgence where they have what's called the SIS, the Sports Intensity Scale, and things like that are tools that states are using. And then she's a regional representative for us. I gave her that title. I don't know even know if it's right.
It's true. It's true.
It's true. Okay. National Conference of Executives of the ARC. So I really appreciate you coming on because, you serve, I think Dave serves as wise over 300 people.
Almost 400.
400. Okay. You have a family support program that's really well respected. Every year you do a resource day with the schools and people turning 22, or anyone really, not just turning 22 focused, but especially around transition, obviously, because people are so confused around transition. By the way, I just heard the number this year. Chris Thompson at DDS shared with me, it's 1,300 is the number And, before Jean talks, I also, for those of you that are on, so you can let other people know if you want, sometimes, we talk about the issues we're advocating for, but sometimes we don't reveal as much of the detail of how strongly we're doing this or that. Because sometimes we're in meeting with people where if we're sort of openly blasting stuff, except for things that we feel like, okay, it's at the point where we have to blast it, it sort of affects the ability to talk with them privately and cajole and get stuff done that we think can be done. So, but we're always open to talk about where our position is, and you should feel really comfortable on any of these webinars to raise questions and concerns. So I just want to say that because if anything, we're an organization that actually has families who have kids with disabilities that work for it. We have a board that's primarily, disability connected, either parents. We have a steering committee with people with disabilities, family members. There might be only one person on the steering committee that is not personally connected. So it's just something always to keep in mind. So I'm calling the testing issue safety and services. And I'm calling that because I think testing alone is not enough to ensure safety in congregate settings. But it's also an issue for those of you at home that haven't been able to get PPE, right? It's been a real problem. Jean, what are the things, as you know, I'm going to list the theme of sort of in order. How much testing can we have happen, right? So we test everybody once, which we do believe everybody should be at the arc of mass. I'm not saying Jean believes that, but that everyone should be tested at least once. But the problem with the negative is, as someone else told me recently, is that's all it tells me. That person was negative on the result today. If you were with me yesterday, you'd see that Brittany, who has no staff or individuals with positive virus, she still had the mask on. And I asked her, why do you have the mask on? And she said, because we don't know. We can't get tested every day, right? So we have to make sure for the safety of the people we work with. And everyone in her house had been tested, by the way, previously, but they have no idea, right, what the status is today. Jean, do you want to talk a little bit about that and some of the things you struggled with in trying to get a good policy at your organization?
Yeah. So first, thanks, Leo, and I appreciate the opportunity to share with people a little bit of the perspective of the challenges that we've been facing over the last 9 going on 10 weeks. And so much of what we were facing was, at least initially, a huge unknown. And as leaders of organizations, we all struggled with, geez, are we making the right decisions? And some of the decisions that we made early on, we've amended as we've moved through the past several weeks because there's been either additional guidance. So I thought it would kind of make sense for me to just share for folks to sort of understand the perspective of what we did at LIfeLinks CLASS and how it worked for us and what our outcomes were. And if people have questions about the thought processes that we went through, I'll be glad to respond to any of that as well. But we serve 68 people residentially in our formal 24-hour group home system. We serve another 50 odd people who live independently in the community in ISS. We have individual support services.
Okay.
So people who don't have 24-hour staffing, but they live alone in the community, and we provide supports to them to be successful in their community life. Leo said family support services, shared living services, adult family care, AFC programs, and then the 400 or so folks who we serve through day services. So, specifically in terms of safety and services, obviously the services that we've been most focused on over the last several weeks, because that's where the biggest issues are with regard to safety, are for those people who we support residentially, and then by extension, many of our family support services, because we've continued to offer AWC services, and we have a number of staff who are still functioning in the community. So we may not be providing facility-based services, but we have a lot of people out and about doing stuff for folks. So the issue about testing, we knew was really fraught early on. It was very hard to get anybody tested very early on. So we made a decision specific to our group home system, probably about 2 weeks into this whole pandemic, that we would require all of the staff who work in our group homes to be wearing masks and gloves for the duration. And I do think that was maybe one of the best decisions that we made, because I'll tell you horror stories about getting PPE, and that's a whole nother conversation for another point in time. But we were able to get our hands on both N95 masks and KN95 masks. And we then, where we couldn't find enough of those, we were using the standard 3-layer surgical masks with an additional cloth covering over it. And our decision was based on the fact that we thought it would make sense to put a barrier between the virus and the individuals who we support. We knew the individuals weren't leaving their homes, but staff were coming in and out. And as you know, in our field, most of our staff work in more than one situation. And a lot of our staff, again, because a number of the individuals who we support, we have a lot of certified nursing staff on our roster, and those CNAs work in the nursing home system. And as you know, the outcomes in the nursing home side have not been as positive as we've seen in terms of the level of infection in our system. So I continue to think that was one of the best decisions that we made early on, was requiring staff to wear masks.
Yeah, yep. Jean, did you have a less outbreak in terms of people?
Yeah, so I have some numbers to share with you. We have about 150 staff, including managers and clinical, who are providing supports in our residential network. And to date, 94 of those staff have been tested through LIfeLinks CLASS. There is a number of those staff who've been tested in other places. We don't track those numbers because it's not up to us to report those numbers, but we have 94 staff who tested under the purview of LIfeLinks CLASS. Of that number, 35 of those staff tested positive. 37 of those staff have tested positive, and of that number, 35 have returned to work. So right now we have 2 staff who are out on quarantine precautions because they've tested within the last couple of weeks. So that's the staff number. Every single resident in our group home system has been tested. So that's 68 individuals have been tested. Of that number, 16 tested positive. Of that number of 16, only 2 ever had any active symptoms. And we've had no hospitalizations of any of our residents with COVID-19 symptoms.
Wow.
And right now, as of this moment in time, of those 16 positive cases, we have 2 residents who are currently in quarantine protocols in their group homes. And what we did is whenever we have a staff person who tests positive, they're out, and we follow the CDC guidance around those staff being out for 10 days from the date of, and again, in our situation, and I'm going to keep coming back to, I think the masks were a good decision for us. For the most part, most of the staff who we've had who've tested positive have been asymptomatic. Not a cough, not a sniffle, not a blood pressure change, not a drop in oxygen, none of those things. And at the start of every shift, actually twice daily on shift, staff's temperature is being taken, and before they start shift, they're still answering the questions about whether or not they've been in a situation outside of work where they've been exposed to, that somebody in their circle has tested positive or come in contact with anybody who's had COVID-19. So I think all of those protocols have been very helpful for us, and they're actually going to help us with a blueprint moving forward for what day services might look like when we reopen day services and how we'd be handling staff. And then when it, go ahead.
6 staff who either refused or it's been inconvenient to be tested, correct? Out of the, is that right?
I haven't had any staff people who've refused to be tested. Okay. So that's not been an issue for us. We've had, our bigger issue is we've had some staff who have sort of self-selected to be out of work because they've been exposed. And we've actually pressed them to get tested because that's a more, at least at that point in time, it's a better predictor of, yes, indeed, you actually have COVID symptoms that are COVID related. We had a number of staff who went and got tested because they thought they had symptoms and they've tested negative. So that's sort of the other thing too, because it's been a brutal allergy season. So there's been a lot of sort of dry coughs and runny noses anyways. So the other thing that we've really worked hard on is the isolation protocols for individuals who've tested positive in terms of restricting their movement in their homes when that's made sense. We've had some people who it's been a clinical challenge for them, and then when that's happened, we've actually put the entire staff into PPE and managed that house as if the entire house was under what we call quarantine protocol. It's really interesting because we have to work with each board of health where each group home is located, and different boards of health in different communities have provided us with different guidance around how PPE should be used and how often we should be using it and when we're using it and what it means for the other residents in the home. So it's been a little bit difficult to sort of navigate those waters, but all in all, I'm relatively happy with the results. But the reality around testing, and I'm going to go back to what Leo said a few minutes ago, is the testing is only as good as the day that you get tested. So if you test today and you test negative today, it means that you're negative today. It doesn't mean that you wouldn't be positive tomorrow, because you could have an exposure that doesn't show up until it shows up.
So the real debate here, Jean, really isn't that whether, I mean, we're fine, and this should be really clear. We've advocated that everybody gets at least tested once, right? That's not even a question. The real question, and by the way, our families and people out there, they're reflecting what our general society is reflecting, right? Because of, I mean, I've heard universities are saying they want to have testing right on site, and they want to do it whenever they can. But here's the problem. You invest in testing to the nth degree and don't get enough PPE or personal protective equipment. Just let me say it out loud so people know what we're talking about. From your perspective, that's what saved the people in your homes. Like even though you had to wait, and there was weeks where there was no test. So since April 10th, 15,000 people have been, I think it's 16,000, by the way, I was told yesterday, 5,000 staff in pop-ups, because the staff were being called when the ambulances first came, which was great, the DDS. By the way, these were great steps. It's just the ambulance company would let you know the day before they were going to come at 3 p.m. So if you have staff off duty, for them to get to the house at 3 p.m., then sometimes same day, right, Jean?
Let me be clear. We got, in some instances, we got phone calls 40 minutes before they showed up. So it was virtually impossible to get every staff person tested.
So it's great for the people living there. It's great for the staff on duty, but it wasn't going to, you know, but the pop-up tests, which happened shortly thereafter, were huge, because then you had one actually at your site a week or two ago. I almost came to that one, by the way, just to do a baseline test myself, but I couldn't justify it, you know, because I had hay fever. So I'm assuming, you know, it's clearly what I have, you know, and I would feel embarrassed to take someone else's spot. But clearly, the PPE is what you think. And then the attestation and verification, and I'm using that term, but also whatever you do when people show up for work. You're doing temperatures. I talked to someone who I respect, not a chapter leader, but a person who's a very well-respected residential and, well, DD director of services, big system. And she said, no, we're not taking temperatures. She said, we are going through a checklist. We are having them test, you know, and then we're, you know, basically if someone refuses to test and we're concerned about symptoms, they're being treated that they have it. They go, they leave. And I think CDC says 10 days. Is that it, not 14?
So the guidance is, it's 10 days from the date of testing.
Yeah.
If you're asymptomatic, it's 10 days from the manifestation of the last symptom if you are symptomatic. So it's been a little bit of a moving target.
Target. Okay.
And the other thing that we've done is we've almost had to manage each positive test literally almost on a case-by-case basis, because there's just so much that surrounds that positive test result. The other thing with regard to testing is, so first is the availability of on-demand testing, which we really need to have, because even with individuals who, we've had some individuals who've had a dry cough, for example, probably more hay fever related. We've had a lot of struggles with, then calling the personal care physician and saying, so we have this individual, they have underlying healthcare conditions, they're living in a group home, there's a dry cough, we'd like to take them for a test. And we've had some personal care physicians who said, no, wait and see if something else further develops before you take them for testing. So we really do need to press for a capacity for on-demand testing. So as soon as someone feels the need to be tested, or even just wants to be ruled out that they're not positive, because there's peace of mind associated with knowing that you're not positive. And again, the need to sort of balance this off on a case-by-case basis. We've had some families or guardians and who said, I don't want my family member tested. And we had two families who did not want their family member tested. And we really had to work very, very closely with those families and enlist the help of, some DDS staff. And we've reached out to some physicians as well to really, I guess for lack of better terminology, convince those families of the need to get the testing done. And I don't know, families are going to make the decisions based on what they feel is in the best interest of their family member. And we do have one individual in our system right now who, because of underlying behavioral issues, we've not been able to get him tested. Twice he's been given 2 different medications to help with anxiety with regard to the testing, and even with 2 different medications. So we've tried 3 times to have him tested.
Right.
And he's just not going to tolerate the testing. He's not in a home where there have been any positives. He's not exhibiting any symptoms, and we're sort of okay with that right now. I'm not sure. I really don't know, Leo. I'm a little stymied at this point as to how we would actually get him tested if he does become symptomatic.
Very intrusive. It's really tough for him to handle.
Yeah.
I bet you he's not the only one, by the way.
Right.
You know what? It's 11:30. I'm going to tell everybody right now, I'm going to keep this going for a little longer because we haven't even talked about visitation. What I'd love to do, Jean, is open it up for any questions, any comments, any opinions. Carrie, let's do that. And are there any opinions, things people want to say about this? That I do think we really have to fight for testing on demand, it sounds like, and also PPE. Nationally, we're working with the ARC. That's a national problem. Gloves have gone from $10 to $11 a box to $20 a box. So it's like highway robbery. And we need them when people are helping people with activities, daily living, and the like. And the individual and the family wants to feel safe. And we haven't even gotten them to families yet that have PCAs, right? If you don't have the virus determined in the home, Mass Health is not going to have enough PPE to give you for your home. So you got to wait till you get sick for you to be able to get PPE, which doesn't make sense, obviously. So that's a real national problem. We have to step it up. There also, Bill Gates funded a home testing strategy in Seattle, a pilot, and the FDA just stopped it a week ago. I don't know what that's about policy-wise. That would be a huge help, by the way. And so anyway, so anything, Carrie, on the question line, or should I be checking it?
Let's see, my screen has frozen, so I can't see the chat, but what I recommend is people just unmute themselves, and if you have a question for Jean.
So Giassi just mentioned he was recently tested. If people can see the chat, it was negative, but the actual phrasing was undetectable burden. Not sure this is meaningful unless I'm tested again. I still wear a mask when I go outside. So do I, Giassi. I wear a mask.
Yeah.
And then Beth's asking, why did 2 families say, what is the reason? Because we're hearing the opposite. Families want the testing. Obviously, that's what we're hearing. What do you, Jean, why do you think was it a religious thing? Was it fear of the behavior? Was it?
it's sort of a combination of different things with different families. There is some cultural stuff that happens for some of our families, where there's a cultural stigma attached to having a virus. It's not specific to COVID. It's just sort of this general, and that's just one of those things that we have to work through. There were a couple of families who just felt that the intrusiveness of the testing was going to be too much for their family member, that their family member wouldn't understand what was going on. So we had to do some work around that. And of course, we have to do work with each one of the individuals in terms of preparing them for the testing that was being done, kind of the way that we do any kind of preparation with folks to, have any kind of medical visit. So it just took a little bit more TLC with a few of those families to get them to understand. There's some fear. If I don't have any symptoms, then why do I need to be tested? And I've heard that from a lot of folks out there is, I don't need to be tested, I don't have symptoms. So just moving past that. And again, part of what we want to do is make sure that, we're supporting people to the best of our ability. So if somebody is positive, that we can, put them under the quarantine protocols and support them to get through to the other side. And again, until we get to antibody testing, we're not going to know.
So, Jean, Diane asked, in your case, no one went to the hospital. So what did you do when people tested positive? Well, what treatment did they get? More fluids, more,
Right. So for the vast majority, with the exception of 2 of our residents, everyone has been asymptomatic. So no one has there's not been an active sickness that had to be managed. So what we do, and again, this is a pretty broad brush because it's different based on individual clinical presentations of each one of the people who we support. But we assign particular staff to be working just with that individual. And that staff person has to be in full PPE, so gown, glove, mask, the whole 9 yards, face shields, foot coverings, the whole 9 yards, and that individual is sort of segregated within the household. Some of our homes are big enough that they can move between their bedroom, a bathroom that they're the only person using, and sometimes there's go ahead.
So but in terms of how the 2 that were symptomatic, like, did they get more fluids? What are the kind of treatment things you did do in the home? I know you have some CNAs, but
right. So again, we'd be following what the doctor's orders were in terms of what that person should be receiving. Again, most of neither of the cases resulted in anything more than sort of significant cold kind of symptoms. So a cough that lasted for several days, a fever that lasted for a few days. So the treatment for that was, fluids and care and comfort kinds of things until people got to the other side of it.
So my brother-in-law had this in Colorado, and he got a really bad lung thing. And we used to do something in my family, which is sit in the shower with the heat. And that actually did the trick for him in terms of and he didn't have a bad episode till he was almost done. It suddenly popped up. And I don't know if you had that experience with suddenly this one day where the fever goes high and the lungs get, no, you didn't.
No, we didn't have that at all.
That's great. Yeah. That's great.
Yep. Pretty mild cases, I would say.
So, and then I'm trying to see if there's one more. I think that's, okay. Going to live with, I'm sure it is. Diane asks about people returning. Those that have gone home, the family, you're going to have to test them before they return?
We would have. None of our individuals went home. Mom and dad, no one took their family member home, so we didn't have to. We didn't encounter that. Everyone has stayed put.
And then Chris mentioned in the chat, if your family member has to be heavily sedated, family might want to refuse. So that's another reason. That's a great point, Chris. There are people, so you had the example, the person that never got tested because it just you tried a couple of things, you're not going to torture you're going to
Right.
not torture
Right. And we're
them.
not, and we weren't advocating for heavy sedation. It's usually like a Xanax or something to just kind of take. These are the same meds that people who need a medication prior to dental procedure just to calm them down, sort of to take the edge off. And we tried 2 different meds. And it is a really, if you've been on this phone, if you're on the call and you have been tested, it's a very uncomfortable test. And when you have someone coming at you with a very long Q-tip heading up your nose,
right? And then Sarah asks, establishing guidelines for now and ongoing. What should DDS be doing? What would we need some guidelines for sure.
For you.
Yeah.
So everyone, that's what I've been hearing actually for people in your position. We want some consistency and we want flexibility, though. We don't want it to be so rigid that it's not human, it's not customized.
Yeah.
But
I think that, it goes beyond DDS. I think we do need to have a very established protocol of on-demand testing. That's gonna provide a huge measure of comfort and relief across all of the stakeholders in right now.
Be safe, all right, when things go back, all right, when people go back, and how to keep people safe in group home.
Jean?
Yeah.
Okay. Yeah.
So I think that the other thing is there, and again, these are things that may be larger than just DDS. It's also having the access to the personal protective equipment, again, on an on-demand basis, because putting a barrier between the virus and the person is one of the best things that you can do.
So Giassi asked, and we're going to take 2 more, and then that's going to be it, because we didn't get the visitation today or some more transition. We're going to do that on Monday, I promise. We're going to start with visitation and then talk about the transition. But maybe we'll talk about the transition first because it's the global issue, and then visitation second. The first one from Giassi says, I'm pretty sure you got positive for COVID-19 because Giassi said the lab said a positive result for SARS-2. I guess it picks up SARS-2. Did not mean one would develop for COVID-19. I didn't know that. So that's the first how much out of the loop I am, Giassi, that I did not know about the SARS-2. Did you know about that, Jean, that the SARS? I knew I've known, I wonder, that's interesting. I wonder if they give you different analysis based on your presentation, Giassi, because I know people who actually had a test for strep and COVID. I had other people that I know had a test. So they took the same data, right? And they ran those tests, and someone else who had an influenza B, that influenza test in general, and the COVID test. Like that was my daughter and her family early on. So
yeah.
So I wonder if there's, I haven't, Jean nor I have heard about the SARS-2 thing, so that might be based on where the folks taking your test and what your symptoms might look like. And then Jean asks, when do you anticipate allowing families to take their loved ones home? So visitation, okay. So really, Jean's question is sort of twofold. All right, should we go a few more minutes? I feel it's already 11:41. I'm feeling bad, but she's asking, how soon do you think that could be? I think, Jean, you're way ahead of the curve on the going back and forth. We'd love to get people just visiting folks at the home. I'm having trouble getting traction on that. And some places are allowing. Have you allowed some visits, by the way?
So we have allowed, and I know some of my colleagues have as well. We've certainly allowed window visits and drive-by visits, and that certainly has been a measure of comfort for both the family members as well as the residents in our homes. We've had a couple of situations that we did do some very socially distant visits in a park. So there was staff with the individual because we were afraid that the individual was going to try to actually physically connect with their family, and that we actually have to sort of keep that distance for the time being. And that made a whole lot of sense in those particular individual situations. So the flexibility to bend the rules is kind of important right now, because you have to be able to meet families and individuals where they're at. I think in terms of,
said they've been doing too, those kinds of driveway or window,
Right. Right.
wearing masks. And you've gone a step further than that. You've done sort of what I heard Jean Goldsberry did with, she was
Right.
doing more, but it sounds like she had more staffing. I don't know if that's somehow affected by you staffing.
no, we just do it within the routine. What's hard is when you do it for one individual in the home, but you can't do it for all of them all at the same time. That's a little bit more challenging. And in terms of the visitation of families being able to take their family member home and then bring them back, I think it's related to, again, the availability of on-demand testing and or a vaccine. But there is this reality in terms of again, it's all wrapped up in physical distance and PPE and all of the practices that are currently in place for society as a whole right now. So, if the rest of if you're not visiting with the rest of your family, except for being 6 feet apart and everybody wearing masks, that would be the rule for anyone, including the individuals who we support. And we haven't yet sort of figured out, well, how can you put people in a vehicle and be socially distance in a vehicle for a car ride that might be 30 minutes long. So it's going to be problematic until it's not, because there's enough mechanisms within society to allow us to manage it. So I think on some level it is going to be tied to the ability to test. And again, even it's just hard. And I guess I want folks here to understand is it's not a decision that there's a real straight up easy answer for right now, because every situation is very, very different. And I think we have to be able to be continued to be allowed to have the flexibility to make the decisions in terms of what's in the best interest of the individuals who we're trying to support, but also meet the needs, wants, and desires of families who are desperate to spend time with their family members. And we want to be able to balance that in a way that's going to be safe for not only the family member and the individual, but also everyone who lives in the home with that individual when the individual returns. So it's going to be nuanced for a while, I think.
Jean, thank you so much. It just didn't, if it wasn't the time issue, I know some people watch this on the internet afterwards too, so I'm going to stop it here. It's fitting that I should go this long, as it's more of a session, and she often goes long. So it's fitting that should have happened to me today. And I really appreciate it. I appreciate all of you that chatted in. I can't say enough about how we need more of that, more of a dialogue. This is wonderful. And we will be advocating hard on these things, hopefully for the right direction. And Jean, I think you captured a lot of common sense, trying to think this thing through. Really appreciate it. And Monday we'll pick up visitation, which Jean got us. Jean C got us going on. And I apologize for us not having the time to do that. And I will do one slide, and that's it in the beginning, and then we'll get right into it. So, Jean, thank you. And we've had a really great to have the dialogue. So, and Anna, hi, special hello to Anna, who's with her sister Diane, known her for 35 years, maybe at least. So, special aid.
Say hi, Leo.
Hi, Mel.
And others of you, I hate to single out one person, but I've known her for 35 years. Such a pleasure to see her with her sister, and pleasure to see all of you. And have a great day, and see you on the other side. Take care.
Thanks, Leo. Bye.
Welcome.
Bye, thanks.
Bye-bye. Thanks, Jean, for joining today.
Thank you.